Really good. So I'm just going to be talking about lamellar keratoplasty from the last course and why you should consider this as your first choice option, and also talk a little bit about different types of lamellar keratoplasty. So these are my disclosures. They don't really pertain to any of these things I'm going to be talking about. So of course, why do we want to even do lamellar keratoplasty for keratoconus? Because penetrating keratoplasty, if you look at the survival curve over here, has actually the best survival when you look at all the indications for penetrating keratoplasty in corneal transplantation. However, if you look at this from the other side, you can see that keratoconus actually is an ideal disease for lamellar keratoplasty because the disease, of course, is primarily in the stroma. It occurs in young patients, so they have a healthy endothelium. We know that the survival, patients who are young are going to survive longer, so we want to give them a better long-term lasting of their cornea. It's an extraocular procedure. You don't actually go inside the eye, or hopefully you don't have to go inside the eye when you're doing the procedure. There's less risk of rejection because, of course, you're just replacing the stroma, not the endothelium. You need to use less steroids postoperatively, and of course, tectonically, the eye is stronger. So if you have any trauma in the eye itself, there's less risk of basically it breaking up. I'm just going to illustrate the endothelial cell count point here with this patient over here who's a 32-year-old. On the right eye has a lamellar keratoplasty, left eye has a penetrating keratoplasty. The visual acuity results are good in both eyes, but when you look at 2 years further down the line, you'll see a massive drop in endothelial cell count in the left eye, which is the PKI, and in the right eye, you're still maintaining quite stability. And the endothelial cell loss in lamellar keratoplasty often follows the physiological cell loss in the eye itself. So which cases do you consider for lamellar keratoplasty? Those currently, basically the advanced keratoconic cases, patients who are contact lens intolerant, unable to do cross-linking or ICL or ICR. You can do it in patients with previous high drops. I'll show you some examples of how to do that. Moderate cones, especially if they're high risk of high drops, you can do OCT to look in detail at the epithelium and Bowman's membrane. If patients who are young, they're males, have high K readings at presentations, are often at very high risk of developing high drops. And of course, patients with Down syndromes or atopes also have very high risk of basically having high drops, continual eye rubbing as well. When you're looking at which procedure to perform, there are different types of lamellar procedures. So you have superficial lamellar keratoplasty at the top over here, and I'll show you some examples of how you do that. ALTK, which we use for moderate cones, okay, it has to be very symmetrical. But of course, if the pathology is involving the whole cornea, you need to basically use a dog procedure, and this is either a pre-decimated dog, as you can see over here. So this is sparing the last 100 microns of cornea from down to decimated membrane, or decimated bearing procedures, and this is either done with air, viscoelastic, a combination of viscoelastic and air, or basically BSS. So where would you perform a superficial lamellar keratoplasty? So this is an example of a patient of mine that was sent to me from Hong Kong, and you can see basically over here in the right side over here, he has this nodular, what we call a keratoconic pip on the surface of the eye itself. And often you'll see this in patients who are long-term contact lens wearers. It's almost like a Saltzman nodule kind of pathology on the cornea itself. In the left eye, you can see it's quite localized. The right eye is basically associated with some scarring itself. And of course, what happened is that this guy has become contact lens intolerant over time. So what we did basically on the right side, the eye with the pip and the scarring, we did a dog procedure. But in the left eye, all we did was a superficial lamellar keratoplasty. You can see basically this over here. This is basically a post-op, and his visual acuity returned 7.5, and then he went back to wearing basically his contact lenses afterwards itself. And you can simply remove this as you basically do any sort of epithelial removal, and doing it ultra high resolution OCT is very useful because you can see the lesion is directly over Bowman's membrane. So once you get a plane above that area, it's very simple to remove. So for more moderate cones, you can think about doing ALTK. This is a 37-year-old Indian gentleman, high degree of astigmatism. I'll point to the fact that it is a very symmetrical pattern over here on the topography, and these are the ideal cases. And the corneal thickness is not too bad. It's about 422 over here itself. And this is one of the key caveats. If you're going to do ALTK in the cones, you must basically have it in somebody basically who's symmetrical. How do you do the procedure? There's two parts of the procedure. We call it first stage and second stage. First stage of procedure, you simply make a flap. This is done with an automated system. This is done with a Moria CV system itself. You cut a flap in one rotational movement, and this is going to delineate your horizontal plane itself. Of course, you cannot do this if the cone is too thin, because you have a higher risk of basically getting perforation. That's why the corneal thickness needs to be around about 400, 420, considering these cases itself. So once you created the flap, we basically will put the flap back down, and basically we'll leave it in place for 2 to 3 months, and we won't touch the eye itself. We'll put a contact lens on the surface and allow the flap to basically heal. Okay, so this is the flap that's been removed from the microkeratome. You wash it on the surface, put it down onto the eye, put a contact lens on. No need to put any stitches in at this time, and just leave it and let it to basically heal. Then what happens is that basically about 2 to 3 months later, you go back. This is a Hana trephine. You trephine within the edges of the flap itself, and you go down to the level of where you basically have the interface, the horizontal interface. Okay, you can pick up on OCT to give you an idea of the depth. And then once you reach the horizontal interface, what you can do is you can simply remove the stroma from the edge, as you'll see in the picture in a minute. Okay, so you go down on the vertical side with the Hana trephine. You get a nice square edge from there itself, then get a Sinskey hook. You go around the edge over here, and slowly you just pull away the area of the cornea that you find vertically, and this will remove the disease pathology from the middle of the cornea itself. Okay. Then we use an ALTK system. We cut the cornea to the same thickness that we're going to basically put over here itself, and then you simply basically suture this in place. The key thing with the suturing, you must remember that when you're suturing in these cases that you suture outside the area of the original flap cut. If you do not suture the outside area of the flap cut, what happens is the flap around the edge will move, and you'll basically get a dehiscence around the edge there itself. You can see you've got a nice smooth interface over here, and that's because, of course, it's become cut by an ALTK system itself. So here you see the donor. So the donor has been cut with a standard Moria ALTK system. This simply clips into place, and then you basically suture the graft with whichever suturing pattern. But as you can see in the suture over here, you must go beyond the flap that you've initially created with the first stage to prevent the dehiscence around the edge. I'll just speed this up because of interest of time, and then you can just suture this basically all the way around. So this is the same patient. This is basically pre-op. This is post-op on the right-hand side over here. So you can see you've basically bulked up the stromal tissue with this technique itself. You can get normal curvature back again. So you flatten the curvature, you bulk up the stroma up to normal 643, and then if you need to do any refinement, you can do some refractive surface ablation to refine the result from there itself. Now, for more deeper lesions, of course, you have to do DOLC. There's different DOLC techniques, so I call it pre-decimase or basically decimase bearing techniques itself. And when you're assessing patients, you have a balance. If you go deeper, you have a higher risk of perforation, but they do get better visual acuity. If you go more shallow, the surgery can be more successful. You have a smaller risk of perforation, but the visual acuity is not so good itself. So when you're assessing patients, it's important to pick the right battles. If you have a cone like this over here, of course, you can do a big bubble DOLC. I'll normally assess the patients clinically, write in the notes what surgery we're going to go for, so I know automatically this is the best thing to basically go for this patient. In these kind of situations with high drops, I do a manual basically technique. There's no need to go down to decimase because this patient will still do well afterwards itself, and I'll show you how we do it. What's the evidence in the literature that less stroma gives you better visual acuity results? Is a paper from Vincenzo Saricola from Italy. And what you can see is over here on this table, if you compare the results of pre-decimase DOLC versus normal decimase-bearing DOLC, you see that initially in the post-operative visual acuity outcomes, they are better in the decimase-bearing procedure compared to the pre-decimase DOLC itself. And of course, if you leave a little bit of residual stroma, depending on how much you leave itself, you're going to basically get a degradation in visual acuity. However, if you look at the complications with respect to decimase membrane perforation or rupture, it's higher in the decimase-bearing procedure compared to the non-decimase-bearing procedure. This is our own data from SNEC published a few years back now in AJO, and likewise you see the same trend where big bubble DOLC actually gives you better visual acuity than you're able to attain with penetrating keratoplasty. And the reason why you're able to get better vision is because you get better alignment on the posterior surface and the anterior surface with DOLC compared to penetrating keratoplasty where you only achieve this on the anterior side. But the key thing about doing DOLC in your younger patients is the long-term risk of complications. If you look at the complication rates of DOLC over here on the left compared to penetrating keratoplasty over here on the right, the complications are much less in the DOLC cases because they do not need long-term steroids, so there's less risk of having raised intraocular pressure or basically cataract. Of course, epithelial complications are about the same, but the key thing is, of course, your risk of rejection is much less with DOLC compared to penetrating keratoplasty. But if you can't achieve a big bubble, do you have to convert to penetrating keratoplasty? The answer is no. You basically will carry on with your pre-decimase DOLC procedure, and with time, the visual acuity will pick up. And the reason why that happens is that you get stromal remodeling of the graft-host interface at the level of basically where the graft is basically touching the residual stroma, and that will improve with the visual acuity over time. So the last area is basically high drops. These cases, often most people will convert to penetrating keratoplasty. You can do a DOLC procedure. We don't advise you to do a big bubble procedure itself, because of course you'll rip the decimase membrane, as you saw in the previous video. But you have to bear in mind that if the high drops in the, previously is on the visual axis, you will get a residual scar there itself. So you may not get 20/20 vision, but the patients do maintain their own endothelial cell count. This is the last video I'm going to show. This is one of my cases. It's a young Indian boy. He basically has a very big scar on the visual axis. Previous high drops done 6 months ago. So what we'll do is we'll use a technique basically where I'll take off the first layer of the stroma, Don't go to the area where the hydrops is, because you'll definitely get a leak if you basically open up the hydrops in the area. So you can see the area of the previous hydrops over here. So using a blunt dissection technique, what I will do is I'll remove the rest of the residual stroma by injecting BSS to swell up the stroma from that area, and slowly remove this around the whole of the area, around the area of the hydrop scar. I'll just speed up the video in the interest of time. So as you remove the stroma itself and you get closer to the area of hydrops, you will see you will get leakage from here itself. So you can see here the stroma over here. I'm getting closer to the area of hydrops, but I've removed all the stroma from around the peripheral area. And of course, as you get closer, you'll see you will lose the anterior chamber. It will start to leak, and then you need to keep on refilling the anterior chamber with air to basically be able to maintain some structure in the AC while you remove the final areas. Okay, there we go. So there's your hydrop scar over here. I've got a bubble in the anterior chamber. The anterior chamber is very, very flat when you basically doing the surgery. Then what you do is you simply put on the graft, try to do it all in one, because of course you don't want to cause a rip in the descemet's membrane, because there's already a hole in the descemet's membrane. Then you will suture the eye itself, fill up the anterior chamber with a lot of air to keep the eye pressurized itself. And what you can do is, if you can see the area of the split over here, which is basically over here, you can realign the endothelium if it's not basically aligned already, by keep this at very, very high pressure. Otherwise what will happen is you'll see a double anterior chamber on the next day itself. So this is the result. This is in pre-op, 6/120. This is basically post-op. If you look very closely, you can see a separation where you had previous hydrop scar. This is a higher view magnification, and you get to about 6/12 at 3 months, and we've started to remove some of the stitches now. So in conclusion, there are distinct advantages of doing DOLC in basically keratoconic patients. This is our survival curve over here. Our DOLC survival at 10 years is about 84%. Of course, you can use older tissue, you can do repeat surgery, and you don't have any issue of steroids. I think other future promising treatments include surface ablation, combining with cross-linking. Of course, you need to be careful about doing this in cone cases, and you need longer-term follow-up. And of course, one of the interesting things I've seen more recently is lenticular reimplantation, combining with cross-linking, combining with PRK. Thank you for your attention. Thank you for allowing me to talk.